Welcome to our show, everyone. I'm Tim Hayden, and I'll be your host. This is going to be a big show. Our guest is Dr. Marshall Partington. Dr. Partington is a double board certified plastic surgeon in Kirkland, Washington, with more than 30 years in practice. Dr. Partington has helped thousands of patients in the greater Seattle area and around the world to realize their aesthetic goals. Let's welcome Dr. Partington. Hello, sir. How are you doing?
Oh, hello, team. I'm great. Thanks. So nice to be aboard. Thank you for inviting me on this important.
We appreciate you being here. Well, we'll start out. You want to tell us a little bit about yourself? I mean, you've got a huge resume. I couldn't even get part of it in the introduction.
Pages of our lives. Well, I am so, I think the first and foremost thing is I'm so happy and thankful to do what I do, and that is be a plastic surgeon because I think it has such direct bearing on people's lives. And as you said, Tim, I actually now focus and specialize in cosmetic surgery. My roots go way back. I was a general surgeon, trained at the UCLA program for 7 years, and then went on to do microsurgery. In fact, I was the director of microsurgery at the University of Pennsylvania and also at Children's Hospital of Philadelphia. And microsurgery is really steeped in reconstruction, transplanting tissues and organs. The first neonatal liver transplant at the University of at the Children's Hospital of Philadelphia. Wonderful, deep sort of deep dive reconstruction. And since that time, things have gone on. I've evolved. I do a lot of reconstructive work abroad. We have organizations much like your foundation where we support other surgeons taking care of children abroad in Asia. But here at home, I now focus a wonderful team on plastic surgery, aesthetic surgery, cosmetic surgery. Yeah.
But you also have a lot to do with involved within necrotizing fasciitis surgeries and situations, aren't you?
Yeah, I have. I've had quite a lot of experience with NF, and it's interesting because through you and my understanding of our mission here and the foundation, it's surprising to me how little is known still by the public about necrotizing fasciitis. And so I was so thrilled to be invited to come on board and talk to you guys, because that's the number one thing is the education about NF. It's in large part a preventable problem. But boy, if it hits, it's got to be taken care of right away. Otherwise, it is a nightmare. And we all have experiences we can relate about the scourges of
Yeah, you're definitely right about that. There definitely has to be more awareness brought to it. Um, are what are some of the treatments for wounds after the debridement? We'll just start right there. Uh, as
Okay,
far
well,
as
yeah. So you've already started with the big word, debridement, and maybe many in our audience knows that term. Dialing back, um, usually necrotizing fasciitis, as you well know, can start with most inconsequential injuries. It could be a nick of the knuckle, or it could be even presumably just a little scratch or a bug bite or something. And it's all about how the healing process then evolves from there. So the first and foremost thing is to recognize that there's an injury, little open wound, cut, scrape, is to clean it off well. That's number one. If you learned about washing your hands, couldn't be more important with preventing necrotizing fasciitis. But if and when it develops and rapidly goes through these signs, which may be just a little redness, tender swelling, usually it'll start showing evidence that there's something more going on. For instance, extreme pain, much worse than you would think from the ostensibly the cut or the puncture, the scrape. That's the first thing. And then there may be very commonly flu-like symptoms. Somebody might get a high temperature. Wow, from that little thing, high temperature, nausea, vomiting, diarrhea, as if you got the flu. And it may not have been associated with the initial wound. But keeping track of that wound as it gets more red, tender, swollen, maybe starting to get a little purplish, touching it, there's a little sort of crackly feel to it, possibly air under the tissue. All that is almost beyond the point of no return. So, of course, as our audience knows, the key thing at that point is to really seek early medical attention. And I would say, too, in all respect to my colleagues, many of my colleagues are not even very familiar with how common this can be. And in that case, I don't even think it hurts if somebody goes in with a real concern to the doctor or to the urgent care. They can say as much as saying, I just want to be sure it's, you don't have this flesh-eating bacteria, do you? I mean, put it out on the table, because it ramps up the evaluation of a wound to a whole different level, which may be life-saving, because the time is of the essence. So you don't want it to just sort of be sitting in the back room on a stretcher waiting to be seen. Now, your question, Tim, about debridement. So debridement basically means cleaning off the wound surgically. And this is a very, very important aspect. If a wound is recognized as rapidly advancing to necrotizing fasciitis, which means there's an invasive bacterial infection, usually group A streptococcus, right? Group A strep. If that's happening, oftentimes what's happening at the wound is, I would call it a hot iceberg. Hot iceberg meaning, okay, it's tender red hot at the top, but just like an iceberg, underneath, there's a whole lot going on that you at first can't see or appreciate. But that is this necrosis, or dying off, of the connective tissue, potentially the skin, the soft tissue, the fat, the muscle. All that is rapidly getting eaten up by this bacteria, hence flesh-eating bacteria. So oftentimes you can't tell all that, but that is what is triggering off these symptoms of headache, extreme fatigue oftentimes, nausea, the fevers. Suddenly people aren't peeing, their urinary output is dropping down rapidly. This is potentially endangering all those organs to the point of going into shock. So debridement is, from the surgical point of view, the first and foremost thing. Recognition, diagnosis of the problem, but then a prompt debridement. And that means pretty much drawing a circle around what you think is the enemy, promptly getting to the operating room to do this generally. Demarcating the enemy, and then cutting out all that involved tissue. And just as we say, we used to do a lot of cancer surgery. I did with cancer surgery yesterday. It was different from what we used to do with big scale removals of large tumors. One can't ever be, as a surgeon, you can't be timid about dealing with and removing the problem. It takes a very careful, well-trained, aggressive approach immediately to the problem with confidence, going in and getting outside the border of this hot iceberg, of this, not a cancer, but it's like an enemy, like a cancer that is so rapid. So debridement represents cutting out and getting down to healthy, viable tissue, whether that's down into the muscle, whether it's removing muscle with that. You can't think about how big the hole is going to be until you've taken care of the problem. And then, this segues, I know, into the question. Then what do you do? What do you do with the hole? Right?
Yes.
Okay. So things have evolved beautifully over time. Fortunately, the bacteria still remains a terrible predator. But the way we deal with wounds has really evolved a lot. Certainly in my career, I've seen tremendous changes. First and foremost thing we want to do is get rid of all the bad tissue. And sometimes we're not sure. So before we do anything, we want to be sure that's done. And it may mean, okay, getting the patient all set, doing the operation, putting on moist packs and whatnot, and lots of antibiotics systemically, sending them back to their ICU bed, usually at this point they're oftentimes in an ICU, and checking that wound a couple of times each hour to see that there's no more evolution of the problem outside of what we claimed as clean. Once we're confident of that, and if we're not confident, if we think, oh God, wait a second, you know, the vitals are still all messed up, and we're having problems, potential multi-organ system failure, systemic shock, all these things, those need to first and foremost be dealt with. Okay, which may mean going back to the operating room too and doing a fresh clean of this wound. But once the flames have settled down and down to the embers, and then go down into the healthy tissue, that really is much more in the realm of the reconstructive plastic surgeon. When that's the case, then we sort of assess the nature of the wound. There are important ways that we still want to take care of the wound. I think many of your viewers may be familiar with a wonderful invention called a wound vac, right?
Yes, for sure. I've heard of. I was lucky when I went through mine. I didn't have one, but I've heard all about them. The love-hate relationship.
That's right. Tim, I just want to highlight again to our listeners that you are a survivor.
Yes.
And ladies and gentlemen, it's wonderful to have somebody who's been on both sides of this issue, and you, like all your foundations, are doing such a worthwhile thing being on the educational side now. But there are a lot of lessons I learned from you with this. So the wound vac is, the wound vacuum system. And it's a brilliant concept. Basically, if you picture an area, say, by the way, necrotic fasciitis most commonly affects the limbs, the arms, the legs, the hands, the feet. It can affect the torso, it can affect the head, yours is the hands. Yep. But it doesn't stop there. That's the point. It keeps its way quickly all over. You can overcome the patient. So picture, imagine that I have this on my thorax, and fortunately it was recognized in time and cleaned up. So now I've got this, call it what you will, but we fondly call it a shark bite, right? Shark bite. Our big bite now, but the good news is although it's normal skin here, we've got a little bit of a Grand Canyon here, maybe down to bone, maybe down to the muscles. We may have sacrificed a nerve or two that go to the hand. There may have been tendons lost or not. We have to assess what's going on with that wound, and a good way to start healing that wound is to place a wound vac. And that basically is like a big, here I'm in the camera, a big medical sponge, sterile, it's done in the operating room, inside that area. And then we cover it over with basically an airtight sheet of almost like a cellophane, but there's a little tube that goes inside under the cellophane into the sponge, and then it's attached to another unit off-site, up next to us, to be at the bedside. So when you turn it on, it's a vacuum, and so it has just the right settings to have the right tissue tolerance to start sucking air and fluid out of this wound, and so you'll see the sponge suddenly smush down from being fluffy underneath down to a little tight, usually black, little black pancake. And with it, it's pulling all the edges of the wound in. And this, we've learned, is a tremendously important phase to go through with many complicated wounds, because in the majority of times, it will take a wound of size X and get it into size half of an X over 2, even smaller. And what it does is it incites a tissue reaction to increase blood supply all around the healthy tissue, bringing in new blood supply, and it tends to help shrink the wound that nature does an amazing job. You say, man tends the wound and God heals them. Well, this is man doing everything we can to encourage that healing of the wound. So the wound vac is a really important thing.
Yeah, the most I heard about the wound, the worst I heard about the wound vac is where people's experience trying to keep it suck where it's sealed because the machine kept going off saying it was unsealed. So that was where most of the issues were that I've heard of with the wound vac.
Okay.
But
And
I've
that's
heard wonderful things about it. Wonderful
it's a
things.
wonderful thing. It is a finicky thing. It drives people crazy. It makes this funny little gurgly sound. I mean, I think they could work on that a little bit, but it has this kind of popping sound that keeps people up at night. I think there'd be a way to deal with it. But it is a brilliant thing. The key is that if it loses suction, if it for any reason gets an air leak, then you're going to hear that crazy sound, and then you know that you've got to do something to kind of tend. I mean, it may be that the tubing is a little off on the wound vac, sitting over on the bedside or on wherever, but it may well be that some of that cellophane is up and it's gotten a little mucky wet around the wound, and so it's not sticking well. And usually, if you're in the hospital, they've got a little alarm going on. Come and they doctor up on the wound site itself and get that going again. So you're right, it is finicky and it's not a one and done. It usually needs to be kind of groomed.
So, what is the next step after you graduate from the wound vac?
Okay, and that's not everybody graduates at the same time. It's not like a 4-year college and you're done. Sometimes people, I guess the point I want to make is this: the more we let nature fill in the hole, the better, in the sense that if you take a shark bite on the arm, you got 2 of them, and you compare the 2. If you use a wound vac and you let that happen, you're going to find that the base of the wound and the side of the wound are going to sort of come up a little bit. They're going to shrink down, a little bit like a swamp closing in on itself. Okay, so the time that one devotes to that is strategic, and that is worthwhile. If you take the same shark bite and say, I just debrided it yesterday and I don't see any more redness around it, looks pretty good to me, let's go to the OR and let's put a skin graft on it. Okay? Which is still a very good way to close a wound. The issue is the moment you put a skin graft in the trough of the wound, nature has a way of signaling, hey, we're done with the closing up of the wound. We're just going to cap it off now. So for the same wound, if you go immediately to a skin graft and it's a geographic deformity in the extremity, you can plan on it staying. It's not going to fill in with granulation tissue, which is the proud flesh. Granulation tissue is what nature is. It's sort of like a raspberry colored tissue that is full of blood vessels that is part of the healing of a wound. If we allow time, and the wound vac helps us, for that tissue to build up more and more and more, it's going to fill in its own hole. But again, the moment you cap it off with a skin graft, which eventually will come to pass, you stop that process. So it's a big decision, and reconstructive surgeons are very familiar with kind of the yin yang, or when to go with the step over from the wound management to the wound vac to the actual closure of the remaining defect.
What is the best, after you get your skin graft and it takes, what would be the best treatment for that to help that heal and grow?
Of the skin graft itself.
Of the skin graft, yes, sir. Sorry.
Yeah. Oh, no, that's right. Which is a process, by the way. A skin graft, I still think, is one of the miracles of nature. The fact that we can shave off skin from one place and put it on another. I should roll this back. Much of what we talk about in the treatment of necrotizing fasciitis and the wounds and the reconstruction is very akin to actually what we do in burn surgery. People who have terrible burns, which are a little bit analogous to necrotizing fasciitis, because a burn just happens like that, right?
Right.
A burn can be a flash burn or just a flame burn that just marauds the tissue and makes such a sudden change. Necrotizing fasciitis is about the next fastest thing of a wound in nature. Cancer is a slower growth thing. NF is a quick thing. when we do skin graft, whether it's in burn surgery or in necrotizing fasciitis reconstruction, we will usually use what we call split thickness skin grafts. Okay, we differentiate between split thickness and full thickness. Full thickness means that our skin is basically the epidermis, the little onion layer on the skin. Plus, underneath it is the leather layer. The way a leather shoes, that's leather dermis of an animal, and it's that leather dermal layer which is where new growth of the skin comes from. Okay? So if it's a full thickness skin graft, we're taking that full dermal layer, and it means that wherever we've taken that full dermal layer from where the donor site where we've taken that person has a full thickness wound. It's interesting to note. You take a full thickness skin graft from someplace, and you take it off. Usually we do it on the legs or the buttock or something, or the scalp.
Really? I didn't know that.
Yeah, scalp is we'll talk about that in a moment. That's an interesting thing. But wherever you take a full thickness, generally you want to think, well, you're kind of robbing Peter to pay Paul. But with a full thickness, you've got to be able to deal with that and expose that donor site in a way. Otherwise, all you're doing is leapfrogging big holes, right?
Right.
So usually with this kind of wound care, we use a split thickness graft. And a split thickness skin graft means that we are shaving off the onion layer, the epidermis, plus a certain variable depth of dermis. And we have instruments to do this, and we set this with a little micrometer. So it's very specific how deep we go, because we want to leave enough on the donor site that can heal in and not require kind of similar treatment to what, we came to drain the swamp over here. We don't want to make two swamps that are now a problem. So that will heal on its own. And then we have the split thickness skin graft. Okay. Usually with a split thickness skin graft, one of our concerns is we want this wound to breathe a little bit, and it's got a lot of juices and everything else we want to get out. So we will oftentimes mesh the skin, and you're familiar with it. Yes. By meshing, you put it through a little machine. You harvest these sheets of skin, just a little bit like wet tissue paper, and we will put them through a special kind of machine that cuts little tic-tac X's marks in them, so that when you have this skin, suddenly, although it may have been, this by this, it suddenly can expand maybe twice as much, okay, in both directions. Wow. So we can get sort of double, 2x power of coverage. So we're not, we're doubling what we took from the donor site in terms of coverage.
Right, and those reducing the donor.
Yeah, exactly. And again, the donor site can heal from the bottom up because we've left a little skin. And now the area of the wound has got this little lattice work pattern of skin that will all be take. Take for skin graft. Take, is it a full take? And interestingly, nature knows that a way to fill in the little gaps of that lattice work, so that the little skin cells on all those little crisscrosses will tend to work themselves in to the rest of it, so it'll finally be a confluent layer of skin. But when that happens, usually it leaves a patterning in skin that is very recognizable, and it almost is like kind of chicken skin or goose skin, that has little stipples, little bumps. Mm-hmm. Okay.
Yes.
And that can be, depending on where it is, if it's on a face or something, we tend to avoid it. If it's going to be a sort of cosmetic deterrent, we like to use full thickness skin, more aesthetic. Sometimes we don't have the option. Usually on the extremities, we will go more with split thickness. And once that's healed, which is in and of itself an exercise, key thing for having a skin graft heal is that it doesn't get disturbed during the time of healing. Here we have this raw, oozy wound where, yours hand, wherever it was, right?
Back and we put hand.
And we put skin graft on it. Any movement of that, any shearing of that skin is going to probably mean the skin graft is not going to take, because the skin has to be absolutely immobilized on its bed. Because what's really going on, which is amazing, is that nature, our body knows that on the raw wound base, knows how to say, oh, there's a new ceiling to us. We want to connect to that. And so microscopic little blood vessels grow up out of the base of the wound. Meanwhile, the little blood vessel remnants that were in the skin that we shaved off are there to recognize and say, I'm over here, and they actually connect these little microscopic tubules of blood vessels to then suddenly nourish the skin. And this is a process that takes 7 to 10 days. However, the early part of it is the most critical time, and any little shear force on that can suddenly take all these little happy little reunions of blood vessels and shift them, and then it doesn't work. So immobilizing a skin graft is a very important part. Interestingly, I know in my work, I have on a number of occasions used the wound vac, not only to clean up the wound, but then later to apply on top of a skin graft to get that complete immobilization through a suction process of the skin adherent to the bed. I don't know, I know we've done that a lot in burn settings and stuff as well. Probably many of my have had good experience with it.
But not every skin graft takes, right?
Not every skin graft takes, exactly. And when it doesn't, it's a double loss, if you will. You know, psychologically, it's a devastation. Oh, God, it didn't take, and you have to so support these patients psychologically through this process, because they've just been through a scary event in their lives. And then if they see that they're not healing, it's a big deal. And of course, it means that we have sacrificed an area of skin someplace else in the donor site. Now, generally, we don't go right back to that. No, we've got to now go to an adjacent site or another site for donor skin. And we're just sort of, trading off patchwork from the donor sites to get more skin going. If a skin graft doesn't work, just like in medicine, if anything doesn't work, we've got to stop and think, what happened here? Why didn't this work? Just like we want to know the diagnosis of NF right out of the gate, as we go through the longer processes of reconstruction, if there's any glitch in it, we've got to make the diagnosis of what went wrong. Usually with a skin graft, what's gone wrong, indeed, is that there's been some sort of shearing. But there are a lot of other things that could go wrong. If fluid accumulates underneath the skin graft, makes a little tent, a little fluid blister, it's going to lift that skin off, and you're not going to get the adherence. If there is residual bacterial infection, which is why we came to the problem to begin with, that's going to immediately kill that skin graft. So again, the point at which we do a skin graft is only after we're very confident through these different stages. Yeah.
What you were saying, to touch on something you said, a lot of survivors get really frustrated because they feel like they're not healing quickly enough, or they're not progressing enough. And what you said, everybody's different.
Yeah, everybody's different. Oh, I'm sorry. Go ahead.
No, go ahead, sir.
Well, everybody's different, and everybody heals differently. I mean, the fact that everybody doesn't get necrotizing fasciitis is wonderful, but the fact that up to as many as 20,000 people a year in this get is something. Everybody's different. Also, some people are more prone to it. People who have some kind of immune deficiencies, whether it's diabetes or some autoimmune problem, even rheumatoid arthritis. These are different autoimmune issues that people can have. And then therefore people heal differently too. And of course, nowadays we're so connected on the internet and everything, and whether it's healing from a devastation like NF, or even healing from a breast augmentation, people generally get online and they're checking and think, gosh, the people in my chat room, are doing much better than I am or something. It's distorting, and it can be very sort of anxiety provoking. So the best thing is to just really hang with your care team, because they're going to reassure you that things are going smoothly, or if they're not, why they're not, what we need to do different.
So, what type of things can be done to promote good healing? To help your body along.
So, okay, and specifically in the setting of healing after an app, right?
Yes.
Yeah. Well, we've got to address any and all root causes. If someone were more susceptible to having NF in the beginning, in the first place, why did it happen? I mentioned diabetes. Diabetes is a good example. Somebody is a diabetic, and particularly if they're not in control and their glucose is not in good control, boy, we better address that right away, because that's going to highbox all the healing, whether it's a skin graft or healing, actually just getting over the infection. So getting control of that. If they have underlying cardiac problems or circulation, all that, these are all things that can contribute to poor healing. So we want to optimize the big picture for them medically, number one. Antibiotics are an important part of this regimen, mainly to treat the NF, and usually we will continue antibiotics for a variable period during the early wound healing stage, and the possibility that there's some remnant of infection. So antibiotics, in and of themselves, once the infection is gone, do not necessarily promote faster healing. Sometimes people are very anxious to feel because they're fearful of this happening again, and that's a bad idea. That it depresses the immune system. As a surgeon, I'm not a pill pusher per se, but I'm very big on nutrition. Nutrition is a very important part of our healing. So optimizing all our parameters of nutrition and having plenty of hydration, water, having plenty of protein. Protein's super important. When we have an open wound, protein just flows out of us. Interesting. If you take a little sample of that serum coming out of the wound, it's so heavy in protein. So it's like, if you've got a wound, you got to think like you're eating for two in a pregnancy. You've got to feed yourself to keep up your general level, and then you've got to really supplement also for this wound.
So is that what that clear liquid coming from a wound is? I've always wondered that. I never really knew. I just thought it was like an oil from your skin.
Yeah, with NF, of course, you get that little red thing. You get to be a big red thing, and it hurts way more than it should. And now wait a second, I'm getting a blister. Now the blisters, and you might start to ooze grayish fluid, really foul-smelling grayish. These are all signs that you already need to be in the hospital, right? So that initial thing with NF and fluid is that's sewer water for the wound. That is not good. Once we've cleaned the wound out, the wound being open and not having its skin integument, not having its coverage, it just wants to just leak out precious bodily fluids. And the yellow fluid that you're talking about generally is a serum. If you draw somebody's blood and you have it in a test tube and you just put it on the counter, you let it sit, invariably the red cells which carry our oxygen, which are a big component of the blood, which makes it so dramatically red, they settle out. So then suddenly they get down to the bottom of the test tube. We actually measure whether they're 40%, 42%, 50%, and this is what we call our hematocrit. Okay, normal hematocrit depends on different people, but is around, certainly 40 is a good number. If people have 55, that's too high. If they've got 23, that's too low. But that's that red cell fraction. And above it is the yellow, which is plasma. And in that, there are all sorts of important things. The serum, I should say, serum. And within the serum, you have a lot of other factors going on. A lot of it is proteinaceous. It has a high albumin content, and that's where we're talking about the protein. But it also has a really important healing element, like platelets. Platelets, I'm sure a lot of your viewers know what platelets are. There are those little magical elements within the blood that are, are absolutely crucial to blood clotting. So if you get a cut, the body signals, these alarms throughout the system where the blood comes through and carrying platelets, and the platelets immediately are activated and they release growth factors, which send signal, and it's amazing. It works, right? They send signals throughout the body saying, "Hey, get down to sector 6. We've got to break, and we got to stem the bleeding. We've got to send in fibroblasts, which come in and then knit collagen to start melding the wound together." Okay, all of that is in that yellow serum. So it's pretty important, and when we lose it, we've got to compensate.
Okay, what about scars? What is the best treatment for scars?
Well, let's see. Not all scars are created equal. Different scars represent sort of different injuries. We talk about how scars are tattoos, but with just much better stories. Everybody who's got a scar has got a story, right?
Mm-hmm.
Sometimes scars can be in the setting of can be just the skin graft. Now I don't have skin graft color because it's a little different from my adjacent skin, and or it may have a waffle appearance from the fact that it's in a split thickness skin graft. It may even along the edges of the skin graft. The skin graft may be fine, great. Wish it never had happened, but there it is, and it's now a sealed wound. But along the edges, we may see what we call hypertrophic scarring. But actually, I'm glad you brought this up to me because it's good to talk about scarring. There's so much confusion about a lot of types of scar. Depending on what kind of scar it is, that speaks to what kind of treatment you can use. So hypertrophic versus keloid. I think most people have heard this term keloid.
Mm-hmm.
That's a term that is used
Yes.
a lot. In fact, it's a term that is very poorly understood. I mean, most patients come in saying, "Oh yeah, no, I keloid very easily. If I'm going to put an incision there, I keloid," and I have to see a scar that they have, and they'll show me like a C-section scar, and it looks pretty good, except it's a little ridge, whatever, and they say that's not a keloid. A keloid is a very unusual, it's a unique form of scar pathology. Keloid is not a cancer, but boy, it sure tries to pretend it is in the way it works. You make a little incision someplace, or you get a little cut, or somebody goes and has their ear pierced. You have a little hole, and then over time they develop a big mushroom. I'm sure some of your viewers know what I'm talking about. They get a big knot, scar tissue. And maybe not just a knot, but a big, as I say, mushroom. What's that about? It's not an infection per se. It is scar tissue, and keloid is a scar that happens way out of proportion to the initial injury. Again, make a little earlobe piercing, but then get something the size of a golf ball. That's an example of one place. It makes me think the worst keloid I've ever seen, probably about 25 years ago or something. I was working in Africa, in Western Africa, in Mali, and there's a lot of patients. And this little gal, she's 12 years old, came into a clinic, and she was a beautiful girl, beautiful face, and she was coming in with her mother and grandmother, wearing all these beautiful robes, just lovely satin cloth, with gorgeous colors and pretty face, and just no smile on this girl, just no. And her generational support brought her in, sat her down, and she just looked so sad. And they wanted to be sure the door was closed, which of course they did. And then they started to unwrap this big turban of beautiful silk colors, and she had, as if she had two cauliflowers. Okay, African girl with black dark skin, and these two black cauliflowers sitting one on each shoulder.
Oh,
Size
wow.
of a cauliflower, this big and this big, kind of almost the size of a head. And these were keloids from ear piercings, right?
Oh,
Kind of
wow.
ceremonial ear piercings in her particular culture and tribal, they would do sort of ceremonial cuts and knowing that scars would puff up a little bit and that. But for her, she developed keloids, which completely took over her ears and made these
Right.
huge things. We had to take care of those. And you never. And the thing about a keloid is if you cut it out, sometimes it is like pouring oil on the fire because it'll come back
Hmm.
bigger. In fact, you can make a little in one place, and a keloid may form there, but then it walks around and develops like potatoes of scar tissue far away from where the scar happened. Usually, it doesn't skip jump. It usually is one sort of blobby train of scars that continue to go out near. That's why I say it's sort of access to cancer, but not a cancer. Okay, that's unusual. And most people have hypertrophic scar. Hypertrophic means hyper is excess and trophic is growth. So it's like over the top growing. It's when you have a line scar that develops this big, either pink or black, big, thick worm of a scar. But it's right staying bound to where the initial injury or incision was. Treatments for that. They range all the way from non-surgical to surgical. Okay, we have to be very careful to make sure we have a diagnosis that it does not keloid. Generally, pretty straightforward. Because if it is, we've got to be very careful about the surgical. Oh, we'll just cut it out. We have to be very careful that we're not just creating a bigger problem. Ultimately, that may be the answer. For a hypertrophic scar, things range all the way from. Sometimes, we like to prevent scarring, and as soon as we make an incision, my patients, we send them home using a special scar cream that has silicone. Silicone is a great ingredient. It can be used as a gel to place on incisions early on to try and prevent that scar. So preventative measures, number one. If a hypertrophic scar or unfavorable scarring develops, then we think it's going up different levels. In some cases, it may be appropriate to inject it with a form of with a sort of analog of cortisone, analog, triamcinolone. These are different compounds that we can mix in with a little numbing medicine, Novocaine, lidocaine, and put directly into the scar tissue. We call this an intralesional injection. And that can be effective sometimes in really kind of deflating the stuff, because basically what that's doing is putting this milky blanket on top of an ongoing inflammatory process, which is what the scar was predicated on. That's what heals us, not infection, but inflammation. And so sometimes inflammation just keeps going on and on and on, and it keeps the scar looking too robust, as if it's too early stage, locked in an early stage. So Kenalog might help it. Other things that we do for scars may include things like microneedling. Maybe many of our viewers may know what microneedling is. Microneedling has all sorts of applications, but beyond what we do cosmetically to improve skin character and quality, we may use microneedling, particularly longer needles on a little roller, numb up the area so it doesn't hurt, because the longer needles hurt. And I'm saying longer needles. These needles may be 1 millimeter long, 2 millimeters long, something in that range. And when we roll that over a scar, and we particularly in our skin put in vitamin A, C, and E oil, just taking normal skin and rolling and putting in vitamin A, C, and E, by rolling it first and opening up the scar tissue or the normal skin by this rolling of little needles that penetrate, opens up the skin, and the oils that you put on go in 44 times more effectively than if you just do it on intact skin. So we take advantage of that with scar tissue and get that vitamin A, C, and E oil into the skin. And actually we use this in burn units as well to help with scar healing. And then, if the scar is just not really responding to these things, if it's sizing it up, that it would be probably more simpler to just cut it out and hope for a better scar. We might directly excise the scar, drawing a line around it, both sides, and then cutting it out and then putting it together. I always talk about that's when surgery and hubris comes in, right? Because sometimes the surgeons will look at a scar and say, "Oh, boy, I could do a better job than that." That may be true, but it's important to know whether it was a poor surgical technique with not opposing the skin edges just absolutely perfectly to begin with that created a poor scar. That's one of or was the scar closed with too much tension? That can create a poor scar. Or it might be the little English the surgeon puts on the way he puts in sutures and really fine sutures and whatnot, which is a big part of good scarring and healing. But to just egotistically say, "Oh, I can fix that scar," we have to be sure we have the diagnosis of why the scar isn't great to begin with. So, yeah.
On that subject, with the scar tissue, what a lot of survivors experience even years later is their scar tearing. Is there something they can do to prevent that? Because I know my co-CEO, she has one right now. Her scar's torn up, and she's 4 years out from hers.
Yeah. This is right. You go through the whole healing thing, and then you have these. Frustrating just to have to wound, tend the wound, but also I think psychologically too. Anytime you've been through some kind of horrible trauma, there's PTSD involved. So when a wound opens up again with a tear or whatnot, I think we need to recognize to people that all that's going on, whether they consciously feel it or not. When that happens, usually what we're talking about with that scar tissue is that it is unstable. That's the term we like to use in surgery. An unstable scar, meaning it doesn't have kind of the horsepower to hang around intact. And it may well be that the scar is so thin in terms of its thickness that it doesn't have much, if any, dermis, what we talked about, the leather layer, which is what really gives more resilience to a scar. And it's more of that onion skin epidermis. And those scars are very thin, and they do generally not hold up to stress strain, whether it is some kind of torsion, fraction, abrasion. Those are issues. If it can be healed with simple means, great. I go back to the microneedling. One of the interesting things about microneedling is it's what we call collagen induction therapy, CIT. Collagen induction therapy, by pricking the little blood vessels underneath the skin with the needle, with the roller needles. It is signaling those platelets, our friends, the platelets, to build, bring in fibroblasts and build up more collagen. So sometimes we can deal with an unstable, thin scar with microneedling. We may see NeoL, all this, to try and build up the thickness of the scar, of this tissue, this scar tissue. That's a pretty good first line. In many situations, the reason the scar is there is it was our best alternative to getting the wound closed. And if it becomes problematic over time, it may well be that we have to sort of reconnoiter and think, well, maybe we need a different solution instead of this unstable skin coverage. And that might mean regrafting it. It might mean going up the food chain reconstructively with other things, like maybe using a flap, a local flap, where we took off some cancer on a gal's chest yesterday here and on her chest, on her arm, and although this is you have to go, if you're going to remove this, you got to leave a margin that is clean, and you end up with a pretty sizable hole, not too big to be able to just pinch it closed, right? Mm-hmm. And if you've got a circular hole, to get that closed, you can't generally just do that. You have to sort of make a little eyeball ears out the side, right? To pinch it, and that can be a big thing. So sometimes we will use plastic surgery techniques to lift up adjacent skin and move it over and sort of cheat the difference and pinch out tissue, and we call those flaps, local flap. The local flap is using something sort of next door to the hole, and we may move that over. Another kind of flap is a transposition flap, where we may say, well, we're going to take a little piece of skin and underlying tissue that has a blood vessel and outline that and lift it up and bring it all the way over, maybe put it through a hole and bring it up. We may do a breast reconstruction using something like that. Tummy tuck skin and fat that we use, that we ordinarily would remove in a tummy tuck. If we're doing a breast reconstruction, that's a good source to bring up and take care of, remove a scar and make a breast out of tissue from a different place.
That's where Lindsay's NF was in her stomach, and that's where her scar has split, is on her abdomen.
Oh, really? Okay. Now that's an example, depending on what the scar looks like and how big it is and whatnot. I mean, whenever we can, we look for a twofer. Sometimes if the scar is low and is in an opportune place to just ellipse it out, might sort of call it a mini tummy tuck, and take out the scar along and pinch a little skin to get fresh skin up. It depends the nature of the scar. But,
will that microblading, will that micro needling work on scars, say 3 years after? Would it help them?
Yes,
it would.
Yep, because as long as you own your platelets, they're there to help you. And so, that whole idea of old scars and new scars can be helpful.
So that might be something they would ask their physician about.
Yes,
is the microblading.
Yeah, micro needling.
Sorry, needling.
You're going to think they're talking about their eyebrows.
That's where my mind went when you first brought it up, and you said most people have heard of it. That's where my mind went, was women's eyebrows.
Yep.
Is there any special treatment that someone should do with a scar from Fourniер's gangrene?
Okay, well, Fournier's gangrene, many of you know what that is. That's a variant of necrotizing fasciitis that is worked in the groin. And I have with that. That, of course, is under the heading of necrotizing fasciitis, it's a nightmare, immediate emergency got to be taken care of. Of course, when it entails the groin and a very radical debridement, this can be, very life-changing. Had to remove testicles, etc. Going deep into the groin, oftentimes removing a whole basin of lymph nodes. It has its consequences, and so the reconstruction and trying to get as much of that renewed with healthy, fresh tissue is important. Talking about scars there, sometimes a scar in the groin is particularly problematic because it may embarrass, it may mess up, it may interfere with, say, leg motion. Somebody might have a constricting scar that they can't really put their leg out to the side all the way, or even have difficulty walking or whatnot. And that can happen in many places, including around the corner of the mouth, pull down the mouth. The arms, the neck, if you have a scar on the neck, it prevents the person to really move their head. In the groin, the scar treatment it's all the same principles, of looking to see, can we work with this scar, can we work with this tissue and improve it? Can we do something if the problem with the scar is not so much appearance, but it's messing up normal function of the leg? Can we do little Z-plasties? This is a term in plastic surgery we use a lot. Little zigzag incisions that when we lift up these little tents of tissue and rearrange them and put them down, we've suddenly made things a lot longer, so there's more leeway for the movement. Fournier's gangrene and its reconstruction is, it's all its own challenges. You're right to bring it up.
I know for sure that if I had my choice, I'll take the one that I had.
Yeah. Yeah.
Dr. Partington, I have learned so much today from you. I really hope that you will come back and do another episode with us.
Oh,
I really do.
I want to thank you, and I want to thank Alicia. I had the privilege, as you know, and I think we're free to share of treating her husband, reconstruction, and all. And I really didn't know until you guys contacted me pretty recently that you have this ardent effort to get the word out and teach about NF. And I'm honored to be on this podcast, and I would so value any and all opportunities to be part of your foundation and to support the important work you're doing. So thank you.
Thank you so much. Thank you for being here. If you could hang out backstage for just a couple minutes, I want to talk to you. I'll be right
Sounds
back
great.
there.
Will do.
Thank you, Dr. Partington. I'd like to thank Dr. Partington for being here today. If you want more information about NF, please visit our website at www.necfasc.org, necfasc.org. Please subscribe to our YouTube channel if you enjoyed the show, and you'll have more opportunity to see more great shows like this. Please be kind to one another and smile. Have a great day.